Hi, welcome to our broadcast. I'm your host, Dr. Sherazad Khan. I'm a hospitalist at St. John's Providence in Santa Monica. Here we are today with Dr. Tracy Childs and Tammy Leader-Fuller. We're going to talk about diverticulitis. As a reminder, the information provided during this event is for educational purposes only. If you have any questions regarding medical conditions or treatment plans, please consult your physician. Now let's get started. Joining me today is Dr. Tracy R. Childs, Chief of Surgery at Providence St. John's Health Center, and one of our diverticulitis patients, Tammy Leader-Fuller. Dr. Childs, would you please tell us a little bit about your role at Providence?
Sure. I'm on the active staff at Providence, and I've been here for the last 30 years. I'm a general surgeon and a colorectal surgeon, and I have been recently involved in leadership positions as chief of staff and now chief of surgery. And I had the amazing opportunity to work with Tammy and take care of her, and she's going to share her story in a bit. And that's me.
Great, thank you. Tammy, tell us a little bit about yourself.
What Dr. Childs didn't say is she saved my tush in such a huge way. I had diverticulitis and I did not know it for about 7 months. And by the time I got to the hospital, which was not a Providence hospital, it was another hospital, I spent 30 days there, and we'll talk about that in a little bit. But Dr. Childs saved me from what I thought was going to be, what I was told by other surgeons was going to be, a colostomy bag. And by the time Dr. Childs treated me, operated on me, and completely healed me, I am fabulous and perfect and feel great.
Wow. Thank you for sharing that. So, Dr. Childs, can you share with us, I think you have a presentation, what exactly is diverticulosis and diverticulitis?
Dr. Khan, I'm so glad you asked. So I'm going to do this, and I'm gonna do this, and I am going to.
I wish I had seen this presentation, because I would never have landed where I did if I had known about this disease that hits a lot of people over 50, as I'm told.
I am going to ask that. I am trying to do this and it's not happening. So I know there's technical people in the background who can do this. I don't know why it's not happening all of a sudden. Okay, I do know why it's not happening all of a sudden. There we go. Okay, so I'm going to talk about an overview of diverticulitis. I want you to understand what the symptoms of diverticulitis are and are not, and what the safe and effective treatment options are. And we'll talk about the outcomes and post-procedure recovery. And then Tammy's going to share her pathway to health. So what is diverticulitis? Diverticulosis is a condition that occurs when small pouches or sacs push out through weak spots in the wall of the colon, and they're most common in the lower part of the colon, called the sigmoid colon. And I'll show you what that is. Most people with diverticulosis don't have any symptoms, and in fact 50% of people over the age of 50 actually have these little pouches on screening colonoscopy. Diverticulitis occurs when a few of the pouches in the wall of the colon become inflamed, and that can lead to complications. Chronic diverticulitis can lead to chronic stricturing or scarring in the colon. It can lead to a significant abscess or infection or inflammatory mass. The other complication of diverticulosis can be bleeding. So it's diverticular disease is one of the causes of lower GI bleeding. So we need to understand the symptoms of diverticulitis, because that's really what we're talking about here. And you can see on the left side of this slide the whole colon in place, and it's it is the left and lower half or part of that slide or that image, I'm sorry, that is the sigmoid colon. And the other half of that image is what diverticular condition looks like. It's those little outpouching. So the symptoms of diverticulitis include pain, usually in the left lower quadrant, sometimes in the middle above the bladder area, because the bladder is adjacent to the sigmoid colon. And when the sigmoid colon gets inflamed, and if it's touching the bladder, you can get urinary symptoms. Fever. So fever is a very important part of the constellation of symptoms of true diverticulitis with infection. Constipation, when your colon is inflamed, it doesn't work right, it doesn't move things forward. And so people feel constipated, and that may be the only symptom that they have of mild diverticular disease is constipation. And fatigue. So when you're sick, truly sick, your body is spending all of its energy trying to fight this infection, and people feel just what we call malaise or fatigue. And then I mentioned urinary symptoms. And sometimes the only symptoms people have when they have diverticulitis, if they're lucky enough not to have the severe pain, is discomfort when they're urinating, not like a regular UTI, which burns when you pee, but sort of a pulling sensation that you get in the lower abdomen when you're trying to urinate or at the end of urinating, that's pulling on the bladder. Very rarely does a diverticular abscess break through into the bladder, and that's called a colovesical fistula. And you know that's happening because you pee bubbles. And so that's called pneumaturia. And it's not common, but it happens. So what are the safe and effective treatment options for diverticular disease? Most people with diverticulosis, we do nothing. If people start having left lower quadrant pain, I don't advocate for treating with antibiotics just based on the fact that they have known diverticular disease on colonoscopy. So evaluation, including a CT scan to actually document diverticulitis or inflammatory changes around the sigmoid colon is key. And once it's documented, then we can move forward with anytime the patient has those recurrent symptoms, it is likely to be related to diverticular disease. Dietary changes. So we all know that a high fiber diet is a very healthy diet. When you have active diverticular disease, oftentimes a low fiber diet to rest the colon is a good idea. And it allows, a lot of people will put themselves on a clear liquid diet for a couple of days and all of a sudden they're better. We don't really know whether that was diverticulitis or something else unless it's documented by CT scan. But it never hurts to start with that. You know, if you're having abdominal pain, it's best not to go and eat a bean and cheese burrito. So oral antibiotics, and somebody who's had diverticulitis and has similar symptoms, including fever and malaise and tenderness or whatever, they may be started on oral antibiotics. And it's not just what you have at home that you used for your urinary tract infection or leftover stuff from a skin infection. It actually has to be antibiotics that will cover the organisms that are involved in diverticulitis most commonly. And those are gram-negative organisms as well as anaerobic organisms. So it's really important not to just treat yourself. I have lots of patients who, you know, take their antibiotics with them when they travel, and as soon as they get gassy, they start taking their antibiotics. And that's not a good idea because there are antibiotic-associated colon infections like Clostridium difficile colitis, which are initiated by killing all the good flora in the colon and, you know, allowing the bad flora to grow and give you an infection. And that's related to the overuse of antibiotics. In patients who are either hospitalized or need to be on bowel rest and can't tolerate orals or they're so sick that they are unstable, IV antibiotics are the treatment of choice. And then once they're improved, a transition to oral antibiotics and home on oral antibiotics. And then surgery is a final option for patients who have exhausted the other options or who have complicated diverticulitis recurrence or either not treatable by medical therapy. Let's talk about some of the myths regarding diverticulitis. First of all, the most important one to get rid of in the back of your head is that nuts and seeds cause diverticulitis. And it's amazing to me how when I tell people they can eat popcorn and strawberries, they get very excited. So nuts and seeds, the whole nuts and seeds deal is an old wives' tale. Another myth is that all patients with diverticulosis will get diverticulitis, and that's actually not true. So we talked about half the population, over 50%, have these little pockets, and you can see by the image on the bottom of the screen, that's a colonoscopy image of what diverticulosis looks like, these little pockets. But only very few patients actually get diverticulitis. Another myth. Once a patient gets diverticulitis, they're going to keep getting diverticulitis. And there are patients who get one episode of mild diverticulitis and get another one 10 years later or never get another one. And there are patients who end up, like Tammy, who never really recognized diverticular disease until they ended up with their first recognized episode in the hospital. And that could be a one and done. So it's very unpredictable, and it's really important to have somebody follow you who can really use the data behind your particular case to determine whether you need to be treated and what kind of treatment you need. The other one is once a patient gets diverticulitis, they have to have surgery, and that's actually not true. We used to say that once you had an episode of complicated diverticulitis, a perforation or an abscess or a hospitalization, you had to have surgery, especially in the younger patient. Now we find that some patients do fine with repeated outpatient treatments or even no treatment at all. And so there's some literature to support that every time you get what you think is diverticulitis, you don't need to be put on antibiotics. And we'll talk about that more. And the final myth and the thing that scares people away from surgery is that diverticulitis surgery means getting a bag. And that even if you have complicated diverticulitis and you're very sick, that you have to have a colostomy. And that's absolutely not true. And it's actually very rare in this day and age that patients will end up with an emergency surgery and a colostomy from perforated diverticulitis. And that's only usually if they come in septic and have to have emergent surgical therapy. So let's talk about some treatment options for diverticular disease. Diverticulosis, I'm going to say it again, doesn't warrant any concern or treatment. All left lower quadrant pain doesn't require antibiotics. Antibiotic treatment is for pain associated with infection, and that's with the hallmarks of fever, malaise. Medical therapy is often adequate, and surgery is reserved for complicated diverticulitis that doesn't respond to medical therapy, or patients who have recurrent episodes with mild diverticulitis that interfere with their quality of life, that causes them to take time off work 3 or 4 times a year, or who travel a lot and are concerned about being in another country where they get an attack and have to be hospitalized. So that's an absolutely legitimate indication. Again, it used to be thought that patients who had a perforation or an abscess then needed to go on to have surgery. But what we found is actually only a very small portion of those patients will go on to have another episode of complicated diverticulitis requiring some kind of intervention. So just because you had an abscess, if it's treated with drainage or with antibiotics and you get better and you have no problem, it doesn't mandate surgery. But I'm a surgeon, so let's talk about surgical options. And I want people to know that this is not your grandma's surgery anymore. So I'm going to show you the way that I treat diverticulitis surgically, including the use of enhanced recovery pathways that hopefully will alleviate any fear that you all might have out there about surgery. So let's talk about enhanced recovery pathways. That involves nutritional prehabilitation before surgery. That means drinking these box drinks 5 days, twice a day for 5 days before you start your bowel prep to clean your bowel out like you do with colonoscopy. And then clear liquid special drink on the day that you're doing your bowel prep, and even a box of the clear liquid drink the morning of surgery. What that does is it's got some special ingredients that decrease the risk of wound infection. And on the day of surgery, this whole myth about nothing to eat or drink before midnight or after midnight before surgery, we've gone away with that and found that patients do much better with carbohydrate loading and adequate hydration before surgery. Narcotic sparing pain management is a big deal. It used to be that pain was the fifth vital sign, that patients weren't allowed to have any pain after surgery, and we flipped that all around on its head, and it's an amazing thing. Ibuprofen and Tylenol with and around surgery, and that's all you'll need after surgery if you need that at all. And it's the way that we do minimally invasive surgery now, patients are so happy not to be given narcotic pain medicine. Minimally invasive surgery has been a big change. So it used to be when somebody was sick with diverticulitis, it was a big midline incision and then worrying about the bag and drains and all this. And I'm going to show you some pictures of minimally invasive surgery, robotic assisted laparoscopic surgery. That's been a game changer. After surgery, how long are you going to be in the hospital? The average of my patients being in the hospital who come in electively for surgery for diverticular disease is anywhere from only 1 to 3 days, the average being 2 days. We get patients, they're not in much pain after surgery. We get them out of bed and walking. We feed them regular food on the day of surgery. We're not using narcotics, so they're not goofy and sluggish and nauseated. Any catheters come out, we get them up walking around, and then they're like, I'm ready to go home. And it's an amazing thing. And when you discharge to home, we encourage you to resume your normal activities. And that means driving as soon as you're comfortable enough to swerve and slam on the brakes and can be a good defensive driver, as well as going back to work. And it used to be 6 weeks, 10 days in the hospital, 6 weeks at home, half time back at work, and now it's home for a week, I'm bored, and back to work, and which is where most people want to be. This is a picture of a robotic operating room, and unfortunately that's a man sitting at the robot, but that would be me sitting at the console. And
it's okay, we can imagine that's you sitting at the console.
Any pictures online of women surgeons, it kind of was terrible. But anyway, that's the surgeon sitting at the console looking into a 3D high definition viewer with his hands in the controls. And that's the Da Vinci robot. And soon to come, there will be other organizations who have robots. And the only thing the robot does is it attaches the arms attached to instruments like laparoscopy, but instead of straight sticks, the instruments are wristed. And you can see that this is the marking of an abdominal wall of somebody who's going to have robotic surgery. And those little incisions are the size of the incision. The right lower quadrant incision gets extended to about a couple of inches in order to bring out the specimen through that. And that's it. And it's pretty amazing. And this is what it allows you to do. So this is a patient of mine who 3 days after a robotic colon resection was back on the set as a set dresser. And when she sent me this picture, I couldn't believe it. But it is the honest to gosh truth. So let's talk about the outcomes in post-procedure recovery. We talked about being in the hospital from 1 to 3 days. In 1 to 2 weeks, you're 75% back to normal. You can be back to work. You can be back to exercising. You can shower. You can do anything you want. Again, 2 to 6 months after surgery, normal activities, normal diet, everything. And then in your future, if the surgeon who is doing the surgery is educated about the importance of doing an adequate resection, the risk of recurrence is less than 15%. So let me give a plug for general surgeons, and I'm a general surgeon. General surgeons are awesome in a pinch for doing this kind of surgery. If you come into the hospital and you're sick, whoever's going to take care of you likely will be able to do it. But colorectal surgeons have an appreciation for the fact that the entire sigmoid colon needs to be removed up to the top of the rectum in order to minimize the risk. And the last picture I'm going to show you is, this is a patient 1 day after robotic surgery, and actually that is 8 hours after completion of his surgery. So he's showing us his port sites and his right lower quadrant extraction site, and he's up and around and dressed and ready to go. So my message to you is, don't be afraid. And my last slide is Dr. Khan, is going to introduce Tammy, and she's going to give her patient story.
Thank you so much for that thorough presentation. That was wonderful. My favorite part was the pose that the last patient had. He kind of had this confident model-like pose with the incisions. And so, Tammy, tell me a little bit about what your experience was, and specifically what makes it unique to share.
So I didn't know that I had terrible pain for months, actually, in my lower left quadrant. And I did go to a GI doctor who told me he thought it was IBS, and told me just to be careful and to eat low fiber foods. He had me on a lot of liquids and mashed potatoes and just sort of clean low fiber foods. And was taking antibiotics and started to get sick. I threw up from them a lot. And so I didn't know what it was. I was feeling intense pain in my lower left side. In fact, I even went to a body worker who puts pressure on, who told me that I had a spasm. Can you imagine? So on top of where this thing was already infected, this big giant man was putting pressure on my body, and I didn't know what was wrong. By the time I figured it out, I ended up in the ER and spent 2 days. They told me I had diverticulitis. Spent 2 days. They put me on a clear liquid diet, and I seemed better. I was on IV antibiotics, and they sent me home after 2 days. And for 2 days, I was home on a low fiber diet and woke up on that Sunday morning of Mother's Day 2 years ago in so much pain, constipated, throwing up, but not throwing up food, mostly throwing up bile, I think, and just exhausted and nauseated, and knew that something was wrong. So my daughter was visiting. They rushed me to the hospital. And by the time I got there, I was in so much pain, like really moaning and groaning. And I have a very high pain tolerance. And I think the moral of this story is, you know your own body. And when your body is in unbelievable pain that is unexplainable, you're the only one who can share that, and you're the only one who can really get help. And so by the time I got there, the doctor in the ER was shocked, because they did a CAT scan and said I had perforated my colon, and I did not know that. So for 2 days they treated me. So at this point now they were trying to get an antibiotic that could kill this. And over the course of, I was there for 3 weeks, and not in your hospital, in another hospital. And they put me NPO with no food for 15 days. And they just kept trying to figure out why this antibiotic could not kill this, and why this strain could not be contained. And what happened is their general surgeons were coming every day. They didn't get me a colorectal surgeon, and those surgeons insisted that this is not that serious in the beginning. But as the week and the second week went by, they said, we've got to do this, and you're going to need a colostomy bag, a stoma bag. I didn't even know what that meant. They didn't know if it was going to be permanent or temporary. But at that point, I just knew my body. I knew myself. I had heard about Dr. Childs. She was in another hospital. I tried to get to her. I could not get an appointment. Here I am sitting in a hospital. And when you're in a hospital and you think you're getting decent care, you trust the doctors. That's how we were raised to do that. But something inside me told me that this is not right, that I needed to get another opinion. I couldn't get one in the hospital where I was. I had heard about Dr. Childs, and I finally got to her through some, you do what you have to do when you're stuck, when you're really sick, and got to her. And she helped me transfer to another hospital. It's not an easy thing to do, dealing with insurance and dealing with all of that. Nobody wants to do that, but you have to be your own advocate. I knew that there had to be something different or better. I was looking for a doctor who could tell me there's another way. There's not only one way. Medicine is science, and there are a bunch of ways to go. And so I finally, it was 2 years ago today, actually, the day before Memorial Day. Her hospital St. John's was packed to the gills. And somehow, some way, miraculously, Dr. Childs looked at my stuff. It's so easy today because you could literally take a picture with your phone of your CAT scan and text it or email it and say, hey, what do you see here? We would never, used to have to wait 3 days for a disc. So Dr. Childs looked at my stuff and said, I can fix you. He's like, we just need to get you here. So she went so above and beyond the call of duty to help me get to St. John's Hospital in Santa Monica. And it was not quick to operate. Said, let's try a few other things. And she tried. And we spent a week kind of experimenting. She came in twice a day. She worked with the infectious disease doctor, Scott Lane, who was incredible, who was puzzled by why why they couldn't find an antibiotic that could kill this germ or this thing that was causing this terrible infection. But ultimately, after a week, Dr. Child said, okay, we're ready. We can go do this. And she did surgery. It really wasn't a big deal at all. Like couldn't believe that I waited a month and in a hospital. Do you know how long that is? They don't let you stay in a hospital for a month. But she would come in every day and she would, and say, okay, I think we're ready. I think we're going to do this and you're going to be fine. And she pretty much assured me that I wasn't going to need a bag. Not 100%, but at the other hospital, there was no doubt. And so at 60 years old, I was turning 60. I'm like, I really want to do this as least invasive as possible. Putting a colostomy bag in required, should it be able to come out 9 months or a year later, going back in to reverse that. And it was going to be a whole year commitment. The beautiful part of this is that the moment she took out that part of my diseased colon, I no longer had diverticulitis and I no longer had any kind of colon disease. That's what's such a miracle.
And did you have pain? How was your pain when the moment that you took it out? And how was your symptom that your body wasn't feeling well for so many days?
After surgery, you're still, I was sore, but I knew right away the pain, the intense pain that I had at the very beginning was, I never had again, because when they put you on no food and you have nothing going through your colon, you're not in pain. That's the whole thing. But at some point you have to eat again. And so Dr. Childs, when I first got to the hospital, said, we're going to feed you. This is ridiculous that you haven't eaten. So they slowly introduced little by little. And through that experimentation is how she figured out where my problem was, what my issue was. And by the time she went in and operated, it really was fine. And I healed fairly quickly. And it really has been, everybody says, what's your diet now? My diet is no different really. That's the beautiful part. She literally, it was like a PVC pipe. She took out the disease part. She took one part of the pipe, she attached it to the other pipe, stapled it, and boom, I just had to take care of myself so that I didn't strain it and break that pipe. But since then, that pipe is solid and I'm a happy camper. I can eat when I want.
I'm so happy to hear that. What I really enjoy about your story, and thank you for the opportunity to facilitate this discussion, is the doctor-patient relationship that you two have created. And that's one of my take-home messages for this talk in general is patients have responsibilities, doctors have responsibilities, and something you said, Tammy, which was, you trust, I wrote it down, you trust the doctors. That's something you've been taught to do. And it's true, you trust the doctors, but you also, like you said, trust your body. And when something isn't wrong, you go seek it, you seek help, you seek advice of a specialist or an expert or your friends or your family, and you share, which is the purpose of this talk, is for all the patients listening, for all the people who are concerned or curious about their bodies and illnesses. The responsibility is really 50-50. And also what you said, which I really loved, was that medicine is a science and there's more than one way to go. So seek advice from whoever you feel that you trust. And also And also, I wanted to ask one last question. In the interest of time, we're already close to 30 minutes. But you know, there's a connotation with our bodies and kind of a complete surrendering to the process when our bodies fail, and it's one of the most challenging times in life, as if probably experienced with a diverticulitis or any new disease and diagnosis. And it's like, I had everything going on in my life, and then now this happens, and how did I get it, and what did I do, and how do I avoid it? And that kind of can you tell me about the feelings, Tammy, that you had with this new diagnosis, and how you felt comfortable or not comfortable sharing with the people around you, and now publicly with the sharing and learning about diseases and diagnoses and your processing of it?
Well, interestingly, I worked with Katie Couric at the Today Show. I was a television producer. So I actually sat, I don't even know if Dr. Childs knows this, I sat on the board of the American Cancer Society colorectal division when Katie did her first colonoscopy live on television. So I knew about it, and it was really that back then, that was in 2000, nobody talked about this. And who wants to talk about poop? Who wants to hear about that? It's not something you really talk to.
just one hand goes up.
Right. It's not something that you really want to talk about. But once you've had an experience with this, your gut health is hugely talked about right now. And it's something that we're all, once you get over 50, you have to deal with. And so for me, I didn't really talk much about it when I was going through it, because I didn't know what the end game was going to be. And frankly, I was scared to death to have to deal with.
Can you tell us a little bit about that vulnerability, and that where you were in that place, in that moments of despair, many days in the hospital, and what it took for you to, kind of stand up for yourself? And
it was scary because every morning the residents and the hospitalists would come in, and every day they would tell me the same thing, which was nothing. Like, we can't help you. Today's the day. You need to make a decision. You need to make a decision. You need to let us go in. It's not going to be a big deal. The bag is not really a big deal. And let's, we got to get this show on the road. They were not happy with me because I asked a lot of tough questions, and I knew, as I said, I knew my body, and I knew that it's so important to have a great relationship with your doctor. I believe that if your doctor doesn't hear you and doesn't understand you and doesn't listen to you, get a new doctor. And Dr. Childs was so attentive, and she never came in with a cell phone. She sat at my bedside and explained everything to me, let me make the decisions with her choices. But she brought in Dr. Lane, who was the, infectious disease guy, because they were puzzled. They couldn't figure it out, but together they collaborated. And I felt like, so I knew that by the time I got out of there, I was going to be healed. I didn't know how. I did not feel that way at UCLA Hospital where I was prior.
Wow. Thanks for being, Dr. Childs, do you want to share any closing remarks or?
We can't hear her.
Oh, you're muted.
Unmute. Okay. So I think that's the whole thing. It's it is about a collaboration. I mean, it's a partnership, and it's also a partnership with the other doctors. Dr. Khan and I work together on patients all the time, and nobody's making decisions in a silo, especially with the patient outside the decision making. And so it was only, I think, my ability to explain things in a way that Tammy could understand, so that she felt comfortable with the decisions that we were making. And then there's no second guessing. And so, here we are. I mean, and it's led to a really awesome friendship. And so, I mean, it's when you take care of a patient for a long time who's sick, and you help them through a really tough situation. I know Dr. Khan has, you develop a connection with patients when you work together and you interact in those most, they're the most vulnerable times of their lives. And it's such a privilege to be able to help people through those really intimate, it's an intimate relationship,
And I think when you have a doctor who you trust and who is looking at other ways, it's not my way or the highway. It just brings you comfort. I had a friend in New York who was diagnosed with cancer in her stomach in the middle of COVID. I said, get on a plane and get to Dr. Childs, get the hell out of Boston where you are. And she got on a plane in the middle of COVID in the beginning when nobody was flying.
Yeah.
And Dr. Childs says, it turned out she didn't have cancer. Dr. Childs, talk about saved her life. She only saved my butt.
That's a story for another.
That's a whole nother story. But the point is, when you trust a doctor, you can let your guard down. When you're sick in a hospital, you're not of sound mind to make decisions when in a language that you've never ever heard before. I never heard the word diverticulitis. Never heard it. And I had a colonoscopy that didn't say I had diverticulosis. So this was a shock to me. I went to the hospital. I thought I had a kidney stone. So it just goes to show.
And you also mentioned that you did medicine for NBC News for 15 years.
Right.
You've never heard the word before.
Never
So there's so many different things going on. And that's exactly what we're here for, is to bridge the gap between the patient and the doctor and to bring awareness and education to everyone. And I want to thank you to Dr. Childs and to Tammy for joining us today, and for everyone listening.
For facilitating.
Yes.
Yeah.
Thank you, Dr.
Of course. Thank you so much. And to learn more about the programs, medical services, initiatives, or ways to give, please visit providence.org and you can catch us there. Make sure to follow us on social media at Providence on Twitter, or under Providence Health System on Instagram, Facebook, and LinkedIn. So
is this recorded? Is this recorded so that somebody can come in and watch it later?
I'm sure it'll be recorded and put up on some website somewhere for sure. Yeah. Yeah.
Bye.
So, all right. Thank you all so much for watching, and contact us for any questions.
Thank you.